Good afternoon, and it's really my pleasure to be again present in Bolivia, not in person, but online. I apologize for that. It's really, again, I'm grateful to the Bolivian Spine Society as well as WFNS Trauma Committee for arranging this, and we are indebted to Marcelo, to Louis Duchenne, and as well as the two committee members, Mirza and Francisco, who's worked very hard to achieve this. My talk for today is spinal cord injury, acute care, and medical management. Our objectives today is initial steps in evaluation and management, treatment strategies in the long-term management, and recommendation for evaluation and management. So initial management, principles of evaluation, imaging protocol, and scores of prognosis and management. The primary injury results from initial traumatic force applied to the spinal cord, and then secondary injury follows the primary injury, including microcirculation disruption, loss of autoregulation, edema, and ischemia. Obviously, we can't prevent the primary injury, but we can prevent the secondary injury. The management includes evaluation, resuscitation, immobilization, extrication, and transport. Log roll, a standard maneuver to allow examination of back and transfer into the back of the boards. 3 to 4 people need to do this. One person holding the head, coordinating the roll. The other hold the chest and pelvis and limbs. And then you can examine the spine when you've turned them on the side. You need to assess and classify skeletal injury, neurological injury, associated spinal injuries, associated non-spinal injuries, and have treatment priorities for it. Evaluation of the patient is general observation, abrasion, laceration, deformities. Any abrasion on the forehead suggests that the trauma may be from front, so you could have a hyperextension injury. Palpation for localization of pain. This is for the spine. Neurological examination includes cranial nerves, motor sensory reflex, rectal tone, bulbocavernous reflex, and incontinence, and primary ABCD care, which is the routine. Initial careful hydration, abnormal hemodynamics are there, and you can have pulmonary edema, so you need to be careful. If you have bradycardia, then you can have atropine that can take care of hypertension. Oxygenation has to be done, NG tube to suction. If there's a head injury, then don't put an NG tube, then OG tube goes in. Urinary catheter in and out, DVT prophylaxis, temperature regulation, electrolytes are done. Imaging studies, nowadays we routinely do CT. Unless CT is not available, then an X-ray could be performed. Canadian C-spine rule is very simple. If there's high-risk factors that involve age more than or equal to 65, dangerous mechanism, paresthesias in extremities. Missed injuries as much in 1/3 patients when we use the X-rays only. So this could be devastating. That's why a CT scan is recommended, and it includes sagittal reconstruction. MRI can further define the level and nature of the injury and the contusions and bruises and any hematoma or disc. But all this may not be necessary in acute situation. If you have an MR available, then fine. If not, then you can proceed and then take it from there. Obviously, MRI helps in deciding regarding the prognosis, etc. as well. Thoracic lumbosacral spine tomogram, AP, X-rays. If you're thrown out of the car, complaining of back pain, you're unconscious, any unknown mechanism, you do that. Complete injury, when there is no motor or sensory function, incomplete. If some motor or sensory function below the affected area is present, so it's called incomplete. Obviously, central cord syndrome, anterior cord syndrome, posterior cord syndrome, and Brown-Séquard are the 4 syndromes you need to know. In this incomplete spinal cord. In anterior spinal cord, obviously you can see that anterior part of the spinal cord is involved, and there is bilateral loss of motor, pain, temperature sensation below the level of injury. There is intact vibration, proprioception, and hyperflexion injury or disruption of anterior spinal artery could be the problem. Whereas if you come into the central cord syndrome, obviously it's involving the central part and sensory and motor deficits. Upper extremities are affected more than the lower extremities. That's typical of central cord. Hyperextension injury, usually in older people having underlying cervical disease. Brown-Séquard, if it's ipsilateral, loss of motor, vibration and proprioception, and contralateral loss of pain and temperature, and you can see why. And you can see that, as you can see, that there's dorsal column up in front, and then you have got spinothalamic tracts and corticospinal tracts in front. So you can see from these that obviously these syndromes are important for us to know and remember. Guidelines, there's level 1 evidence, and in the awake asymptomatic patient who's without neck pain, tenderness, with no neurology, without an injury, for distracting from any accurate evaluation, you do not need a CT scan of cervical spine. In the awake symptomatic patient, high quality CT imaging of the cervical spine is recommended. In the obtunded or unevaluable patient, high quality imaging is recommended as the initial imaging modality. If CT is available, then initial cervical spine radiographs are not recommended. Neurogenic shock and mean arterial pressure, decreased systemic vascular resistance in neurogenic shock. 25% of the patients have this. Maintenance of arterial pressure above 85 or greater for first 7 days after injuries has demonstrated favorable outcomes. So you can see this is way back from the 90s and 2007 that we are able to correct this and improve the outcome of the spinal cord injury. Dopamine, norepinephrine, epinephrine are first-line agents for treatment of this. So consensus statement, phenylephrine is recommended for inotropic support compared to dopamine in patients above 55 years. And that's the reason is that with dopamine, you can get you can avoid reflex bradycardia if you use phenylephrine, because with dopamine it can be a problem. In cervical or high thoracic region, both hypotension and bradycardia happens. So norepinephrine, which has chronotropic and isotropic effect, is a vasoconstrictor of the choice. And then for lower thoracic lesions, where hypotension is usually the result of peripheral vasodilation, pure vasopressor drugs such as phenylephrine may be appropriate. Dopamine for treating spinal cord injury is limited due to its effect on vasodilation and possible risk of reflex bradycardia. Respiratory complications you see in 40% of patients when the lesion is above C4, and if you have that, then this is a predictor of the need for tracheostomy in these HCA patients. And smoking, previous lung disease, and extent of the lesion obviously defines that. Early tracheostomy in these patients leads to a shorter ICU stay and reduction in the length of time of mechanical ventilation. Direct laryngoscopy can still cause spinal movement during manual line immobilization. So in these cases, movement magnitude should be limited in the spinal cord injury. Methylprednisolone, lots have been talked about it. Administration of methylprednisolone for the treatment of spinal cord injury is not recommended. It is not approved by ADA. There is no class 1 or 2 medical evidence. There is class 1, 2, 3 medical evidence that the high-dose steroids are associated with harmful side effects, including death. So we don't use methylprednisolone on its own. There is no good evidence that methylprednisolone is beneficial. In selected young patients with acute spinal cord injury, 24-hour infusion of methylprednisolone within 8 hours may be suggested. In acute spinal cord injury, there's no pharmacological evidence that it should be administered. What about early versus delayed decompression? So look at this Taskus trial. And in this, we showed that if we did these surgeries within 24 hours, the 6 months post-injury early decompression was associated with 2.8-fold increased odds of a 2-grade ACI impairment improvement with no difference in acute complications. So that's what's recommended. Early decompression, there is evidence that a surgical decompression stabilization within 6 hours of partial spinal cord injury will lead to 70% of these patients improving at least by 1 or more ACI grade. If such surgery is delayed beyond 6 hours, there's only a 12% chance of improvement. That's a huge difference. So that's what we need to be aiming at, 6 hours. 10 to 15% of individuals with ACI grade convert to ACI B and D. However, about 3% regain functional strength below the lesion, which is ACI D. Half of these patients who have got ACI B gain substantial functional growth below the lesion, ACI C and D. 86% of those who are classified C and D at 72-hour regain useful motor function. So I think it's important to know that having an ACI is not the end of story. The 10 to 15% of them will improve and 3% will have some kind of function to be able to walk. So predictors of outcome obviously is our Asia impairment scale. That's what we look at. There's a basic score and its correlation with Asia grade. So for example, if you do an MRI and you see that we have given a score from basic 1 to 4, and this is depending on how much of the involvement of the gray matter there is. And as this increases, we know the chances of improvement goes down. And once you've got hemorrhages, which is grade 4, along with the complete involvement of the cord, then their chance of improvement are nil. So this has been shown. WFNS Spine Committee has been involved in various educational activities, and this is our website. I'd like you to have a look at it, please. Especially for young people. And on these, we have got these recommendations and also guidelines for cervical spondylotic myelopathy, lumbar spinal stenosis, cervical spine trauma, spinal cord injury, thoracolumbar spine trauma. And now we are working on lower back pain and lumbar disc prolapse, and that's already in publication. And then another thing that we have recently done is the CV junction pathologies, and that should be underway in a few months as well. And all these are available, and if you just click on these recommendations, you will see that. If you want to see the open access publication, then you can just click and you can download wherever you want, and you can see all these are available online. Clinical syndromes on outcome, we have talked about that. Obviously, conservative treatment alone with 85 to 90% remains the most useful treatment for traumatic spinal cord injury. To improve the outcome, when there is signs of spinal instability, continuing compression of spinal cord, early surgery should be considered. Impact of radiology, presence of facet dislocation and CT is suggestive of poor neurological outcome. MRI T2 sequence is an acceptable method to rapidly screen patients with cervical injury. Predictive finding on T2 sequence, including sagittal grade, length of injury, maximum canal diameter, maximum canal compression, basic score that we have shown before. Diffusion tensor imaging may be promising to predict outcome in both acute and chronic spinal cord injury in future. The impact of decompression, as we've talked about, decompressive surgery is effective and must be performed as early as possible. Data suggests that better outcomes are correlated with surgery performed within 24 hours. There's no evidence that non-operative management is better or equivalent to delayed decompression. Pharmacological treatment as adjunct to spinal cord injury has been a topic of debate. Their role has been proven controversial. In many ongoing trials, their role has negative effect in treatment of spinal cord injury. There is class 3 studies which need randomized controlled trial for its clinical application in spinal cord injury. So again, I'm grateful and thank you all, and hope to see you all soon in person. Bye-bye.